on some OB stuff. So without further ado, I'll turn it over to Josh and we'll hopefully give you something good to think about.
All right, quick sound check here. Good. All right, thanks, Tony. Well, good morning, everybody, and Happy New Year. Welcome back to our monthly education. We look forward to presenting you guys with some good content throughout the year, hopefully. Um, it's always available on Tony's YouTube page to revisit throughout the year if interested in it. For you, those of you who don't know me, Josh Cox, I'm the EMS outreach coordinator with St. Elizabeth. Retired from the fire service a couple of years ago. Worked for Independence for 18 and a half years, then worked through for other various departments in Northern Kentucky. Currently, also Indiana and Ohio certified paramedic and primary instructor in Indiana. So we're going to talk today about some high-risk pregnancy complications and neonatal resuscitation in EMS. We had a couple good case studies that we have to review that we had come through St. Elizabeth in throughout last year. So we'll be discussing those cases throughout our discussion. If you guys have, I kind of put it in the comments, if you have any interesting cases you want to talk about during this session, please put something in the chat and we'll talk about it as much as we can or as much as you want to. And obviously, if you have any questions throughout, feel free to put them in the chat or in the Q&A. So we'll get started here. We're going to talk some about the high-risk OB complications, review assessment of OB patients. We'll talk about some neonatal resuscitation guidelines, assessment of neonatal patients, and then some review of SWANKY protocols for OB and newborn resuscitation. This is kind of intertwined throughout the discussion. And as always, if you're not under SWANKY or Southwest Ohio, Northern Kentucky protocols, follow your local protocols for any patient care. So some epidemiology of high-risk pregnancy in EMS. So some people may go through their whole career, not deliver a baby. But for you to go through your whole career without having an OB patient is going to be pretty rare. So some numbers from 2018 to 2019, 56 million EMS activations. Of those, 8,614 were out of hospital delivery. So very, very small portion of out of hospital deliveries. And then of those, 1,712 were with delivery complications. So complications obviously can vary based on the patient. It can be as a simple complication where it's, you've gone through the warm, dry suction stimulate, and maybe now the baby's breathing some, but needs a little bit of airway assistance with bag valve assisted ventilations. And obviously into thinking about the inverted triangle where we get down to medications where it gets a little more complicated. EMS assisted field deliveries is documented in 3,500 cases of all maternal activations, but only 2% of those with delivery complications. So again, a very small number with complications. And you may go through your whole career without seeing those complications, but that's why it's important to do to practice and do SIMS training with these less infrequent cases that we might see with complicated deliveries. So less than 1% of all EMS activations in the U.S. are for OB complication, including out of hospital deliveries. And then 1/3 of those events, including potentially high acuity patient or complication that may require extensive pre-hospital care. And we kind of touched on that there as far as what those complications may be, as far as getting into assisted ventilations, intubation, and down into medications. Unplanned out-of-hospital deliveries are associated with postpartum hemorrhage, a need for ICU or newborn, and even maternal or neonatal deaths. So thinking about that, people, moms that maybe have not had prenatal care outside of the hospital or outside of their doctor's office. They've just gone through this whole pregnancy and had nothing done for the baby. So lower income, where mom may not have access to a doctor for that uh, maternal care. All right, so OB assessment, some things to think about, and thinking about back to our EMT days, um, going through your basic assessment, and then remembering the number of pregnancies versus live births. So gravida is your number of pregnancies. And these can be confused, especially in those moments where it's maybe you're trying to give information to the hospital and you're trying to think gravida versus para, or if you can't think of that, just tell them they've been pregnant this many times and had this number of live births. If you know that information, obviously that's important on your patient assessment to kind of gauge if this is going to be a complicated delivery, if mom's had, gestational diabetes where the baby's going to be bigger, if she's had previous preeclampsia, been on bed rest, all that kind of stuff is going to play into your assessment. Prenatal care, kind of hit on that or lack thereof. Prenatal care is going to find a lot of potential complications. Um, Mom's maternal age can play a big role in potential complications. And again, things we think about going back to EMT class. I was talking to Tony about um, our textbooks. My textbook, I still have it from when I went through medic classes, just over 1,000 pages. And now you're on a series of books for paramedic class where you're in multi thousands of pages for your book, but they still the still similar complications that we're going to see in the field. So gestational diabetes, where you have a bigger baby because mom maybe becomes insulin dependent, and that causes that baby to be bigger. Placenta previa, abruptio placentae, and we're going to get into these a little bit, so I'm not going to stick too much on them right now. Placenta accreta is a big one. We're going to talk about that because one of our case studies in here presented with that. And then again, have these been monitored during the pregnancy? Has mom had ultrasounds and seen the placenta previa, and now is it rotating around where it's not going to be covering the opening for when the baby needs to come out? And then hypertension, so preeclampsia, eclampsia, obviously being familiar with your blood pressure parameters. Most protocols say 140/90, and that should be, over a 15-minute period where that's trended. If it's staying elevated, they tend to have that preeclampsia. Some maternal adaptations. So obviously during pregnancy, mom's body undergoes significant physiological changes. And this is to support fetal development, obviously. These changes can include increased blood volume, cardiac output. So mom's going to need increased blood for the baby. And this is going to help meet the metabolic demands that the mom and the fetus will need, right? So cardiovascular changes, you get that increase in blood volume, cardiac output, again, meeting those metabolic demands. Your respiratory system, so elevated heart rate and respiratory rate occurs. Obviously, thinking about as that baby grows and that uterus expands and that there's less room for that diaphragm to expand down, causing mom to have to maybe take increased amount of respirations, not necessarily because she doesn't have that full expansion of her diaphragm for the lung capacity. So obviously this is clinically important for us. We have to realize these adaptations that mom is going through. So we're not misdiagnosing any issues that she's not having associated with the baby. So vital signs during pregnancy, these may differ for those in non-pregnant individuals. So our heart rate typically 60 to 100 is the normal range. With pregnant mom, those ranges go up from 80 to 100 typically. Blood pressure may decrease slightly during the second trimester due to hormonal changes and increased vascular compliance. Again, that respiratory rate increase because of the physiological adaptation. And again, understanding these obviously is very important as the EMS providers. So being familiar with those ranges and then recognizing those normal physiological changes to distinguish between typical pregnancy and one that may be developing complications. So some common complications we see with pregnancies: bleeding anytime during pregnancy, and we'll get into these here in a second. Your ectopic pregnancy, kind of again going back to our EMT basic stuff, ectopic pregnancy, and mom or female, I'm sorry, with abdominal pain of childbearing age. So that's when woman starts getting her period until she goes through menopause as your childbearing years. So we don't want to make any assumptions, but you always have to keep it in the back of your mind that ectopic pregnancy could be a possibility. Multi-para pregnancies, again, has mom had prenatal care where she knows this? Is she bigger than she was with her last pregnancy? Has she had any other complications? Gestational diabetes, preeclampsia, eclampsia, and then anemia. Has mom had hyperemesis gravidium during her pregnancy, causing her to throw up a bunch, and now her electrolytes are off? That can be significant to baby too. Supine hypotension syndrome is typically later in pregnancy, where mom is laying on her back and compressing that superior vena cava, causing blood pressure issues. So some bleeding noted during the first trimester, and there's various causes, but here's some of the more common things that may be causing it. So implantation bleeding, this is light spotting as the embryo implants in the uterus. Hormonal changes, these can cause cervical sensitivity and spotting. Cervical polyps or inflammation. Ectopic pregnancy, again, that's an implantation outside the uterus, often in the fallopian tube, but anywhere outside the uterus. Molar pregnancy, that's abnormal tissue growth instead of fetus. Subchronic hematoma says blood between the uterine wall and the amniotic sac. And then various infections that can cause cervical irritation. And then miscarriages, these often start with light bleeding and cramping. These are more common earlier on in pregnancies. Your second trimester bleeding, this is after 12 weeks, so anywhere between 13 and 27. You get placenta previa partially or fully covering the cervix. That's not to say that this won't change. My sister-in-law had this, and she was 42 when she had my nephew. So she was advanced maternal age. They were able to monitor that, and they rotated out of place where it needed to be by the time she was 36, 37 weeks. So no major complications there. So that would obviously be something that would be picked up with ultrasound and monitored. Placental abruption, that's premature separation of the placenta from the uterine wall. And then incompetent cervix, where your cervix opens too early, risking preterm birth. Preterm labor, so early contractions and cervical changes. And again, infections. And then obviously any trauma or injury to the abdomen can cause bleeding. Obviously, these women would need to be seen at the hospital for examination and evaluation to assure there's no complications from the trauma. Some third trimester bleeding issues. So after 28 to 40 weeks or through birth, again, placenta previa abruption, continued risk from the earlier trimesters. The uterine rupture, it's rare but life-threatening, especially with prior C-sections. Bloody show, that's the mucus and blood as the cervix dilates before labor. And in labor onset, you get normal bleeding during cervical dilation. Intercourse and pelvic exams, these can cause spotting due to increased cervical blood flow. And then fibroids or cervical growths that occur during the third trimester can cause bleeding. So some less commonly known complications: hyperemesis gravidium, that's excessive vomiting, kind of hit on that, and this can lead to dehydration, excessive weight loss. Obviously, mom needs to be monitored for this and make sure she's taking in enough nutrients and if she needs iron, prenatal vitamins, that kind of stuff to help prevent those excessive loss of electrolytes. Infections, UTIs, STIs, some can be passed on to the fetus, and that's this torch group down here. That's the toxoplasmosis, rubella, cytomegalovirus, herpes, and other agents such as HIV and syphilis. And the baby can be infected from these at birth. Again, this just kind of reiterating the importance of prenatal care to pick up on anything that mom may be dealing with pre-birth is going to be important. And then this placenta accreta. So there's a spectrum of this, and this is where the placenta implants deeper into the uterus. So in creta, that's where it implants deeper into the uterine wall, into the muscle, and then per creta that it plants that implant and it invades through the muscle into the organ. So if we think about that process of that implantation so far into the musculature and then the organs, obviously that's going to have a significant impact on mom. And this just shows those implantations. Here's your normal implantation, and then accreta getting into the cervical wall there. Increta, it's through the wall and getting into the musculature, and then percreta out into the organs where it's actually pushing into and invading that space out in the organs. Obviously, that can play a significant role. Obviously, it can be very serious. Often no symptoms during pregnancy, but would be picked up on with prenatal care, prenatal ultrasound. It can result in significant blood loss after pregnancy, and early diagnosis is going to be crucial with prenatal care and planning. Just researching this, a lot of times it's going to have to be a C-section with mom. Sometimes, depending on the severity of it, their mom's probably going to have a hysterectomy with this, and they can leave the placenta in place to try to preserve um, mom's ability to have children in the future, where they would go in and take part of the placenta out later. But more likely than not, it's going to end up in a hysterectomy. Obviously, it can lead to premature birth. If not detected, it can lead to severe bleeding and maternal death. Again, can lead to partial or total hysterectomy, DIC, and then maternal death in extreme cases. Just another picture of kind of how that invades the space in there with the baby. So this leads to our first case study. So 911 call for a possible childbirth. EMS responds and they get an update with the patient has locked herself in the bathroom with a child. So EMS arrives on scene. This was a local case. Crew members arrived and had to, luckily it was a 5-year-old child in the bathroom with them. So EMS was able to get the child to open the bathroom door so EMS could get in there and assess the patient. They get to the patient. It's a 30-year-old female in the bathroom. And she had just delivered the neonate directly into the toilet. The baby's still face down in the toilet. So as soon as they found this, additional resources were called, and the infant was found to be in arrest. Just some background on it. Family did not know that the patient was pregnant. She had no prenatal care provided. For whatever reason, she was keeping it secret from the family and didn't want them to know. And obviously, the no prenatal care is going to play a role here. There was a large amount of blood noted on the bathroom floor and in and on the toilet on initial crew arrival. And then the crew on scene, the placenta had delivered prior to mutual aid arrival. The patient was noted to have a significant blood loss upon removing her from the scene to the ambulance. and vaginal bleeding continued. So on the scene, this is before mutual aid arrived. An IV was established and fluids were started. They initially gave her 250 milliliters of fluid, and there's your initial vitals: pulse of 113, pressure of 100/64, and SpO2 97%. So a little bit elevated pulse. Blood pressure is a bit borderline. O2 sat's okay. So when mutual aid got there and does their assessment on them, they find the fundus is still pretty boggy. So they did perform a fundal massage. Um, and with that, after a few minutes of the fundal massage, bleeding was noted to have slowed, and uterine contraction was noted post-fundal massage. So that uterus tightened up for them, helping control that bleeding. They continued with IV normal saline infusion and got a total of 1,000 cc bolus en route to the ER. Blood pressure was stable on arrival at the ED, and there's her vitals on arrival there. Pulse 113, blood pressure is 147/108, and the SpO2 is good. There was pre-hospital notification made, so they knew they were coming. Hospital course, so L&D met the squad in the ER bay, and they did go directly over to L&D, and she went for a DNC post-delivery. So she went to the OR for her DNC. She ended up arresting due to blood loss, but was resuscitated and needed pressor support. So she had massive bleeding post DNC, ended up needing a full hysterectomy and oophorectomy, had an estimated blood loss of 8,100 cc's. So massive blood loss. They obviously did their massive transfusion protocol, ended up transfusing her with 14 units of packed red blood cells and fresh frozen plasma. So with all that going on with her body, she ended up with a elevated troponin due to her arrest. She'd had some cardiomyopathy with reduced ejection fraction. But she did fully recover, was discharged after a 9-day stay in the hospital. And her diagnosis was that placenta accreta causing postpartum hemorrhage. Now, had she had prenatal care, the accreta would have been picked up on. They would have had a plan of care. So she was obviously emotionally distressed at the scene. A normal person wouldn't go into the bathroom, lock themselves in there with another child and have issue with allowing EMS to come in, access, and help her out. Again, no prenatal care provided. This would have likely found the accreta and been had a game plan ready for delivery of baby. So that lack of prenatal care led to complications, including the full hysterectomy, oophorectomy, and almost mom's life. So in reviewing the run report, and EMS assessment was very well done. They recognized the continued postpartum hemorrhage. They did early fluid replacement, that fundal massage, which helped control that bleeding initially. Constriction of the uterus post-fundal massage helped control the bleeding. They had a high suspicion of index for mom to decompensate, so they had their IV fluids going. She's being oxygenated, all that, everything that needed to be done for treatment. So additional treatment, if we look at our protocols, and is that really blurry on your screen? Okay. All right. So vaginal bleeding post protocol, or I'm sorry, yeah, post pregnancy, postpartum hemorrhage. Causes of bleeding in pregnancy will depend on gestational age. Second, third trimester bleeding include that placenta previa, placental abruption. We all know what that is. Accreta is not mentioned in here because it's more something they're going to pick up on in prenatal care and in the hospital. But obviously, considering that any kind of life-threatening bleeding, more than 500 cc's of blood loss. And it's kind of hard to estimate that blood loss on the scene, especially when, there's blood in multiple areas and in a toilet. It's hard to assess that amount of blood loss. But obviously, we would base this on our patient's vital sign assessment. So it's important to get your history, do your physical exam, making sure we're controlling that bleeding, get your fluids going, and be prepared. Postpartum hemorrhage, again, greater than 500 cc's of fluid lost from vaginal delivery. With the funnel massage, again, with our any patient care, explaining procedures and processes becomes really important to, especially in these high pressure situations where the patient is scared, doesn't know exactly what's going on. So making sure you're being a clear communicator with them. Don't just start going and doing that funnel massage. It's uncomfortable. It's a lot of pressure on mom's abdomen to try to get this bleeding controlled and stopped. So kind of, do your explanation. This is going to be uncomfortable. I have to do this to get your abdomen, your fundus to contract to help control bleeding, and explain that to them as clear as you can. Bleeding can slow and then start again, so you can restart that fundal massage. So make sure you get hands-on to your assessment on the fundus. Excuse me, and then feel if it's boggy or if it's contracting down for you, where that bleeding is controlled. TXA consideration. Now her blood pressure came back up with fluid replacement. So TXA, they weren't far enough down. It might have been in the crew's mind to consider it, but it is definitely indicated in continued postpartum hemorrhage, post fluid replacement. Again, just do your checklist. It's going to be 1 gram and 100 cc's of fluid over 10 minutes infused, unless you have any contraindications. And there's your suspected or sustained systolic blood pressure less than 100 if older than 55. Time since injury, if known, that's more on your trauma patients. But in pregnant patients concerned for severe internal external hemorrhage, it's going to be indicated. Again, follow your local protocols if you're not under SWANky protocols. So jumping into and we're going to get back to the baby here in a minute, but just jumping into some neonatal resuscitation stuff from mom. So with neonatal resuscitation, not only do we not want to have complications with mom, even less so we want complications with the baby. So annually, about 62,000 out of hospital births occur in the U.S. So I know that the numbers from what I showed a minute ago, these can be a little confusing, but this is overall. This could be patients that are out of hospital and having birth with midwife at home, that kind of stuff. So these are kind of all inclusive. Up to 10% term and late term infants in the U.S. require some resuscitation to establish effective breathing and ventilation. So some resuscitation, again, that could be as little as warm dry suction stimulate and some bag valve ventilations. And that gets your effective breathing going and your ventilation's going. And then about 1% will need further resuscitation. That's where we get into CPR, compressions, advanced airway, and drug administration. So remember our inverted pyramid of newborn resuscitation there. Is that okay? Okay, sorry. Again, patient assessment, warm dry suction stimulate, bag valve mask assisted ventilations, endotracheal intubation as indicated, chest compressions, epi, and then volume expansion. And this just on the sides shows the amount of intervention, 1 in 10, 3 in 100, 1 in 100, yeah, and on down. So 1 in 12,000 would need, the most extensive resuscitation needed. So that's not a super high amount that we would potentially see. And even over your career, you're not going to see it very often. It's where it becomes important to, if you can do Sims training on this kind of stuff, be familiar with your equipment, get your, if you have practice dummies in your station that you can get out and do these, train on these scenarios that you don't frequently see. So follow your local protocols again. This is from the Swanky protocols. Intubation and suctioning are reserved for newborns with thick meconium who are non-vigorous. So we don't need to necessarily suction every kid when they come out. Now, if they have, again, if they have excessive secretions, obviously you're going to use your bulb suction and just clear those secretions. If you have thick meconium staining when they come out and it's causing an issue with oxygenation and ventilation, obviously you're going to do aggressive suctioning. And if you need to suction via the ET tube, if it's indicated for that thick meconium, you would consider that. Again, you have poor respiratory effort, decreased muscle tone, and heart rate less than 100, then we would consider it. That's for neonatal resuscitation protocols. Positive pressure ventilation, you want to make sure you're using the correct size mask. Use bag volumes with between 200 and 750 milliliters. Don't overinflate. Administer breaths 40 to 60 per minute. Assessed heart rate and oxygen saturation after ventilation is started. And then effective resuscitation should be evident by a rising heart rate. Your assessment of the heart rate is really better done by them being on monitor. You can assess a pulse by, feeling the umbilical cord. You can listen to the baby. It's going to be a little bit more difficult to, even on a full-size neonate, assess that brachial pulse in those high stress situations. Also, oxygenation and pulse ox. This should be attached to the right side upper extremity. And saturations in newborns take several minutes to come up because that closed ductus arteriosus in the heart. So it can take up to 10 minutes for that oxygenation to come up to above 85 to 95%. Just some guidelines again, non-vigorous newborns with meconium stained amniotic fluid. So your initial warm, dry suction, clear those secretions, dry and stimulate, positive pressure ventilation, and then direct laryngoscopy with ET tube suctioning if obstruction is evident. Respiratory support, obviously, and corrective steps if indicated. CPR if failure respond to positive pressure ventilations. Here's this is actually the updated 2025 version of the PALS algorithm. And again, thinking about the steps we're taking, these should be steps. Like when you're doing your protocols, these should be in 30-second increments. And go to our protocols here. Back on the pediatric newborn resuscitation. And this says bag valve, despite 30 seconds of adequate bag valve ventilation. So this isn't a couple seconds and we're hoping to see changes. This is 30 seconds of bag valve mass ventilations. And then, despite that, we're not seeing changes and the heart rate's below 60, we would go into CPR for continued support. And this talks about just the rates and stuff. So 2-thumb encircling or heel of the hand now instead of the 2-finger is the recommended. Again, these protocols haven't necessarily been adapted yet, but the PALS recommendations now are our 2-finger compressions haven't been as effective as we thought. So if you can get both hands around and do the thumb encircling, that's good. If not, do the heel of the hand compressions for your CPR now. There's just some, again, 30 seconds of back valve ventilations. If heart rate's still less than 60 seconds after 30 seconds of compressions and adequate assisted ventilations, then we would consider our epi. If vascular access is not available, this is still in the protocol where you can go through ET tube in these neonate kids. So if you have them intubated, their full term should be using a 3 to 3.5 ET tube. Premature would be 2.5 to 3. Again, being familiar with your equipment is going to be important here. Know your sizes, how your bags are set up, all that kind of stuff, to be able to pull that equipment out and quick and deliver care rapidly. And just some resuscitation notes. Every effort should be made to transport both mom and infant to the same hospital. Resuscitation on newborn should begin with bag valve and supplemental O2. Even healthy newborns that do not require resuscitation can take up to 10 minutes for that SpO2 to come up. So getting that pulse ox on that right upper extremity for that where that ductus arteriosus closes up is going to take some time to pick up and get up to where we want it to be over some time. All right, so back to our case study here. So the baby, so information we know already, right? Mama locked herself in the bathroom, entry was made, baby's face down in the toilet. Additional ALS resources were called. Umbilical cord is still attached and noted to be not pulsating. Baby's non-responsive, not breathing, purple in color, appears full or near term. The cord is cut and CPR was immediately initiated. Just some notes on cord cutting. You want to keep the baby, and this is, in cases where normal delivery, keep baby below the level of the abdomen, delay cord cutting 30 to 60 seconds in vigorous newborns. Again, these are per the updated PALS guidelines. You want to clamp 4 and 10 centimeters apart and then cut in between. Scissors are preferred over scalpel. So again, be familiar with your equipment. If your OB kit has a scalpel in it, be familiar with that. But if you have scissors that you can use to cut, it's a heck of a lot easier than trying to cut through that with a scalpel. As sharp as a scalpel is, if you've ever tried cutting a cord with a scalpel, it can be a bit of a challenge. If you do need to milk the cord, you want to milk it towards the baby, preventing fluid loss. And that's greater than 28 weeks. All right, so the baby is wrapped in a towel to dry off. CPR is continued. They noticed the baby take one agonal breath as CPR is started and no pulse is noted. Baby's removed to the ambulance for continued care. ALS care was provider from the engine crew remained with mom until the additional ambulance arrived on the scene. Baby's color improved with treatment. Suctioning was required. Respiratory effort improved, and within a few minutes, the pulse was regained at a rate over 100. Additional drying and warming occurred, including warm blankets covering baby's head. Within a short period, baby's heart rate began to drop again. Additional CPR was performed for about a minute, and the heart rate jumped back up over 125. Adequate respirations were noted, and assisted ventilations were maintained as needed until arrival at the ER. En route, there is significant improvement in color and tone noted. Crew did note, and this chart was done very well. The documentation was awesome on this run. They did note a small mark on the right cheek and some redness on the head from where the baby probably impacted the toilet on delivery. Transported to local ER, met by L&D in the Bay, and they had them stop bag valve ventilations at that time. And they had the baby had a nice strong cry on the way over to L&D. So hospital route here. The baby's admitted to the NICU with respiratory failure, hypothermia, metabolic acidosis with an initial pH of 7.1. Baby's also hypoglycemic with a sugar of 35 and ended up with a depressed skull fracture on the CT, assumed from the aggressive delivery into the toilet. So the baby's put on CPAP for respiratory failure, rewarming for the hypothermia. Initial temperature was 96.6. It's always something we talk about in any delivery. We do a lot of OB sims, and we don't have a isolate in the back of our ambulance, right? We try to crank up the temperature, keep it as warm as we can, keep the baby dried off, keep warm blankets on it, cover the head up, do everything we can, and we do everything we can. The baby can still be hypothermic, so it's just something that happens. They're able to rewarm the baby in the hospital under a warming light. D10 infusion for the hypoglycemia and the acidosis approved within a couple hours, from 7.1 to 7.33. The baby continued to improve, but due to concern for the skull fracture, he's transferred over to Children's for continued care and treatment and on supportive O2 on transfer. Did good and end up discharged in good condition. So good outcome. Rapid recognition by EMS crew of the situation here. Bathroom door was locked with a child in the bathroom. Think about, scene security, that kind of stuff. Was it an issue? Not for them. Luckily, they were able to get the 5-year-old to open the door for them and immediately access the patient and get to, both patients. Quick assessment and treatment, CPR and back valve assisted ventilations following the neonatal resuscitation protocol treatment. Drying of the infant and heat preservation, ongoing reassessment and treatment, and they transported to the appropriate facility. St. E's is a level 3 NICU, so got them to the right place rapidly. All right, we're going to jump right into our next case study. So another local fire department here, dispatched for a possible OB problem. EMS arrived and met by family outside who advised the patient was in the bathroom bleeding everywhere. And this prompted, before they even got inside, they were calling for additional resources before getting to the patient. Patient found sitting on a chair in the bathroom. She's awake and alert. The patient advised she had to go to the bathroom and felt a, quote, popping sensation, then had a gush of blood. And the amount of blood noted was equal to about a normal menstrual cycle for the patient. Now, obviously that varies person to person, mom to mom. So, that's hard to estimate that exact amount of blood or blood loss. Visualizing that blood in the toilet, was there any clots in it? Is there any tissue in it? That kind of stuff, that's going to be important to note that in your charting. Patient was working earlier in the day and had a lot of lifting. She performed at work, which caused some lower abdominal pain, but no contractions were noted. She has no urge to push or have a bowel movement on their assessment. Mom gives a history of 2 previous miscarriages prior to 12 weeks. Currently 36 weeks pregnant. So she's G5P2, so she's been pregnant 5 times and had 2 live births. Youngest child is 2 years old. She's had no prenatal complications noted and was last seen by her gynecologist on Monday, which was 1 day prior, and gives no other pertinent past medical history. So they did a really good assessment on her, getting all that information, noting that there was no other previous complications, how many kids she's had, how many pregnancies she's had, that can kind of be a predictor of, a complicated birth versus uncomplicated, and how fast mom may go into labor. After patients were moved to the EMS unit, they removed her pants and noted that her shorts are covered in blood, and there was a golf ball sized blood clot that had been passed, but no active bleeding was noted at that time. Here's our vital assessment. So pressure is 109 over 70, heart rate's 112, respirators are 20, SpO2 99% on room air. So she's secured to the cot. They establish an IV, give her a fluid bolus en route to the hospital. The receiving hospital was notified via Pulsera. In both of these cases, the hospital had been notified ahead of time. And there's just their notes out of Pulsera. And she's transported to L&D at Edgewood. Patient was checked multiple times en route to the ER for bleeding with none noted. So these reassessments obviously are going to be important. You know, is mom telling you any information that, you know, is indicating that she has continued bleeding or concerns? You know, is her level of consciousness changing? Is her color changing? Obviously, ongoing reassessments are important. So she's a directed bit to L&D. On EMS arrival to the hospital, report is relayed to care and the nursing staff. Again, going back to vaginal bleeding in pregnancy and postpartum hemorrhage, kind of a review there. Vaginal bleeding occurs up to 40% of pregnant women in the first trimester. Many go on to have normal pregnancies. Cause of vaginal bleeding early include a variety of things. Second, third trimester bleeding causes placenta previa, placental abruption, and this sounds like placental abruption, right? Again, on your assessment, your history, physical exam, um, hallmark of bleeding during pregnancy, support resuscitation and transport. The patient passed any products of conception during or at the scene. Try to obtain those. Now, they noted blood at the scene, but no products of conception with her. So there's nothing really to bring to the hospital. But you want to bag those up, bring them to the hospital with you for pathology to be done on them. Pre-hospital care again. Need my screen here. All right. So hospital course. Suspected placental abruption was confirmed on evaluation. So she had an urgent cesarean section. Baby was delivered within a couple hours of arrival. She did receive 1 unit of packed red blood cells post-op day 2, and then pathology confirmed the placental abruption, and mom's discharged a couple of days later. All right, so on mom's history, again, a lot of this was noted in the patient care chart, but some of this was from the chart at the hospital. So we don't always get, you know, everything, all the history that mom has, right? She had 2 previous cesarean sections, gastric bypass surgery, indicating, and with obesity, you know, she potentially was diabetic previously, but maybe not now. Cholestasis, slowing or stalling of bile from the liver to the digestive system, and a history of anemia. Again, history we may or may not know. Obviously, we would report all this to the hospital as is necessary. All right, so baby with this case, mom noted she could feel baby still moving. There's no prenatal complications noted, and last seen by the OB on the previous day. Mom's vitals remain stable, including blood pressure and oxygenation. Mom remains stable, helps baby remain stable, right? If mom's oxygenating good, she's been eating okay, getting all her nutrients, not throwing up, not having electrolyte imbalance, that's obviously going to be good for baby. We don't want any hypotension or hypoxia. So they were prepared for delivery. They had equipment out and at the ready. That was noted in their run report. Additional resources were already called and on hand if they had delivery. Typically, if we think about deliveries, I mean, this is really an uncomplicated delivery is a basic life support skill, right? As long as everything goes good, but when things go bad, they can go significantly bad, and we have to have those resources there at the ready if things do go bad. So transported to the appropriate facility for mom and baby. Again, Edgewood has the labor and delivery and NICU capabilities, which they knew, and transported to the appropriate facility. Again, delivered by cesarean section. APGAR score was 9 out of 9. NICU admission due to gestational age. So she was 36 weeks at delivery, so 4 weeks early. And she stayed in the hospital for just 2 weeks to help develop her lungs a little bit more, and did well, as discharged home in good condition. APGAR scores don't get, when we do sims, we talk about it. Don't get caught up on it. It's something we're going to have in our run report. But in the moment of delivery, yeah, obviously we're looking at the baby. Are they pink? Are they blue? They have some centralized cyanosis. They have circumoral cyanosis. What's their muscle tone? All those things we're thinking about with these babies when they're delivered. Um, and then when you go chart, you can look back at your references. Most of the OB kits have a APGAR chart in there, and you can reference that for when you need to do your APGAR score. But obviously, we're going to communicate this with the facility. Hey, yeah, they had poor muscle tone initially. We did some ventilations, we warm, dry, suctioned, all that kind of stuff, and now their muscle tone is good. The baby's crying, good, strong cry. They're pinking up and looking better. Don't get too caught up on those specifics. Um, so enhancing patient experiences, clear communication. Like I said, communicating with mom and any patient obviously is important, right? Clear communications, explaining procedures that you're going to be doing um, on every case. If you're starting a line on somebody, if you're putting oxygen on them, talk them through these processes. It is a lot way to enhance that patient experience. Um, Again, pregnant mom, if you're doing a fundal massage, it's uncomfortable. They need to know what's going on with them. You're going to be putting a lot of pressure on that abdomen to get that fundus to tighten up and control that bleeding. She needs to know that. Emotional support, providing emotional support helps reduce anxiety, fosters trust during emergency situations, and these kind of things kind of come over time. This isn't something necessarily we're taught in EMT or med class. We're taught patient assessment skills, we're taught you know IV start skills and monitoring and that kind of stuff. But the communication part and the emotional support kind of comes over time as the more patients you deal with. Privacy, dignity. Obviously, this is important to maintain. One of the common things we do in our OB delivery is we put a patient out in a park, out in the wide open, and we kind of see how the crews adapt to that, and kind of trying to create that situation in a sim lab is kind of difficult, but kind of keeping that in your mind, it's kind of a well, duh kind of thing, right? But in those moments, make sure you're maintaining that privacy and dignity, getting them out of those situations in the wide open and in the privacy of an ambulance as needed to get them away from those eyes on the scene. And then empathetic listening, listening and responding empathetically to patient concerns fosters cooperation and trust. Moms that miscarry, I mean, that can be that's a very severe situation to them, and you need to be very empathetic to those situations, especially with maybe moms that have done fertility or infertility. Um, Pregnancies, that kind of stuff, and that maybe they've lost multiple kids, and it can be a very emotional time for them. So make sure you're taking that into consideration in those moments. So just some key takeaways. Be prepared. Obviously, there's no routine call, right? Every call you go on can be different. Um, be willing to call for additional resources early, you can always disregard crews, send them back home um, if you don't need them. Be familiar with all your equipment. Does your service carry a Browslow bag? Does your service carry just a regular ALS bag, BLS bag, and you have an OB kit sitting up on a shelf somewhere? Be familiar with where everything is in your unit and bring everything in that you're going to need so you're not running back and forth in the moment of need. Your run report should paint a picture of what you saw. Both these run reports were awesome. I mean, painted the picture perfectly. I could, visualize the treatment that was going on between both mom and baby with both of these case studies on here. Again, a lot of people starting to use AI. If and that's a good thing when you learn how to use it. There's a lot of stuff that can be left out in run reports. Those pertinent positives and negatives. A lot of times those are not in the report, and those are really what paint that picture of what was going on at the scene. Um, and then making sure we're noting pre and post treatment. I can go through a run report and see the vital signs trending. Um, and that's fine. You can kind of let that trend that way. I try the way I charted if it's a significant run. I make sure I chart, if there's significant changes in blood pressure or that kind of stuff, any changes with medication administration. In these cases where you give an IV, significant amount of IV fluids, their pressure go up, did it stay down? They have any change in mental status, so their color change, all that kind of stuff is going to be important to help paint that clear picture. Review your protocols and equipment that you don't use often. Again, Sims training is a great way to learn. You don't have to, have us come on site or come out to CTEC and do training out here. You can do Sims training online. There are YouTube videos. There's plenty of resources, but these less frequent cases that we see with, like postpartum hemorrhage, resuscitation, these kind of things that are you don't see frequently are obviously the more important ones to train on. And then obviously transporting to the most appropriate facility. Just be familiar with the facilities in your area. If you're not under, you know, Southwest Ohio, North Kentucky protocols, what do your protocols say? Where do you need to go for your specific patients, be it OB, stroke, STEMI, all that kind of stuff. And then use your communications tools also. We encourage Pulsera use with our facilities. Especially in these more significant cases, stroke, STEMI, OB patients. OB is really good about that two-way communication. They'll acknowledge, say, we'll see you over here in the triage and L&D, or say that they will have a crew come over and meet you in the ER in the squad bay, which is what happened in these cases with these patients. So if you guys have any questions, shoot them in the Q&A or in the chat right now. Or if you have an interesting case you want to talk about briefly, let me know. And I will stay on for a couple minutes here if you guys have any questions.
As always, guys, thanks for coming out and taking a little time out of your day to keep your people educated. We really appreciate it. Uh, we'll continue these. We've got next month, Terry Foster is going to do the bizarre and spectacular, unique cases in emergency care. So Terry's always a fun time, and these are recorded. And again, you can go back and the other shifts, if they want to watch it, they can. You're more than welcome to use this to better your teams as much as you can. And I got 11 o'clock on the button. And if anybody's got any questions, feel free to reach out to Josh um, or myself. And I believe the next one is February 24th. Let me triple check that. Yep, February 24th, 10 o'clock. And I'll send out a invite, and please feel free to attend, share, and we'll see you again next month. Any questions or anything, we're always here, Chris, Josh, myself, to help with any EMS related project. Thanks and have a safe month.
Thanks, guys.